more folks will join us. I'm really excited to get started and hear this talk from my good friend, Dr. Renee Salas, who I welcome on behalf of the Wilderness Medicine Interest Group and the Climate Change and Human Health Interest Group of SAM, our second speaker in our series on climate and human health. And we are thrilled to have her with us this evening. Dr. Salas is affiliated faculty and previous Burke Fellow at the Harvard Global Health Institute and a Yerby Fellow at the Center for Climate, Health, and the Global Environment, Sea Change, at the Harvard T.H. Chan School of Public Health. She is also a practicing emergency medicine physician in the Department of Emergency Medicine at Massachusetts General Hospital and assistant professor of emergency medicine at Harvard Medical School. Dr. Salas served as the lead author for the 2018 and 19 Lancet Countdown on Health and Climate Change U.S. Brief, and will do so again in 2020. Dr. Salas was a co-director for the first Climate Crisis and Clinical Practice Symposium and launched the broader initiative in partnership with the New England Journal of Medicine. She also serves on the planning committee for the National Academy of Medicine's Climate Change and Human Health Initiative and has testified before Congress for the Full House Committee on Oversight and Reform on how climate change is harming health. She engages in research on how climate change is impacting the healthcare system and developing evidence-based adaptations. She lectures on climate and health nationally and internationally, has published in high-impact journals, and her work and expertise have been featured in mainstream media outlets like the New York Times, NPR, Time, and the Associated Press. We are so very excited to have Dr. Salas with us tonight. Renee, I will turn it over to you.
Well, thank you so much, Tracy, for that warm introduction. And thank you so much to SAM and the Climate and Health Interest Group and the Wilderness Medicine Interest Group for putting this together. I know that we are bombarded in multiple ways to try to take our time to sit in front of a screen. And so I'm just really want to use this time to try to share some thoughts that hopefully can be used to begin a discussion, whether here or kind of continuing in your own institutions. And in your own spheres, to really think about how can we emerge from our current moment. So this moment of interconnected challenges, including obviously the COVID-19 pandemic, which has especially impacted all of us on the front lines of emergency medicine across the country and including across the world. And so, you know, first and foremost, my thoughts go out to everyone, and I hope that you and your loved ones are healthy and well, and that you're also taking time to care for yourself during this moment. I know, you know, often as I sort of describe it, that we, you know, life keeps happening on top of what now is a sort of immense baseline that we all are experiencing collectively. And so, at least I know with myself, continuing to try to have grace and understanding with both myself and with others. And in addition, really in the moment of, you know, the climate crisis is continuing to rear its ugly head and show its fingerprints across the headlines as we all digest our news, AKA scrolling through our news, and our long overdue reckoning as a country with systemic racism. So, you know, in this moment, how could we really chart a path forward towards a healthy recovery from this moment as we really try to reimagine and innovate, you know, what that path forward could look like? So with that, I'd like to just talk through a few things today. And so that includes sort of laying a foundation about thinking about how the climate crisis especially is impacting our practice of emergency medicine, because we all really, I think, tangibly feel how it's impacting or how COVID-19 is impacting our clinical practice. But oftentimes I think the interconnections with the climate crisis and what we do every day is sometimes less understood. Then I want to talk about some of the parallels between the COVID-19 pandemic and the climate crisis, discuss some of the intersections, and then try to really focus our discussion around integrated solutions. So I think we are all quickly recognized, at least myself especially, you know, that we can no longer look in a rearview mirror in order to understand what the future looks like. I don't know about you, but I mean, often for me, I will pull up a patient's urine culture results from the past in order to try to decide what antibiotic I should give them going forward. Do they have climate C in my mind, antibiotic resistant bacteria in their history, right? So oftentimes we think that the past can predict the future. But I think increasingly we can no longer use a rearview mirror in order to understand what the future looks like, which really lends itself towards an enormous opportunity to, one, in an evidence-based fashion, really try to understand what the future path is and prepare for it, because you can't manage what you don't understand. But then also recognizing that we need to think differently about the future than we have previously. So kind of thinking about that, I want to just add some food for thought around how the climate crisis impacts what we do every day in our jobs as emergency medicine physicians. And so to sort of help structure that, I'm going to use some concepts that arose through the Climate Crisis and Clinical Practice Initiative, which I had the honor to help launch with some colleagues in collaboration with the New England Journal and other collaborators. And the goal of this, we actually brought together all of the major healthcare systems in Boston, which I'm told was a first, and it was actually surprisingly easy to do. And they even gave us money, which is even a bigger win. So we all came together and we held a symposium to think about how is the climate crisis impacting the care of our patients, collective patients here in Boston, because recognizing that just like the COVID-19 pandemic and the climate crisis, neither of those respect boundaries or hospital territories. And so we're all in this together, and we have to break down existing silos and collaborate together to figure out a unified path forward. And so we did that in Boston, and that kicked it off. And now we've had other flagship sites around the US that are continuing to bring together their own local communities, including Australia, so our one international site. And that is really meant to be a foundation to launch an even bigger initiative where we really try to systematically and think about and comprehensively assess how clinical practice is being impacted by climate change. So acknowledging, right, that this is going to differ based off where we live, because one thing that is true about the climate crisis is that it does not impact every location the same. In fact, before this call, those of us, and I was talking with Tracy and Caitlin and others from SAM about how the climate crisis has been showing up in our doorsteps, and that it can include the wildfires that have become, unfortunately, an annual catastrophe on the West Coast, which is extending wildfire smoke plumes into Colorado and other places. You can also, I'm imagining, since we don't have evidence yet, but obviously there's big concern that the hurricane season, which is also unprecedented, we're using Greek letters in order to name tropical storms and hurricanes, because we know that climate change makes hurricanes slower, wetter, and more intense. So with that in mind, we have to recognize, right, that every geographic region is differently. In addition, that every specialty is experiencing climate change differently and has a different lens with which to approach this problem. So we are generalists as in emergency medicine, and we often act as the safety net for our healthcare system, which means that we care for those that are disproportionately affected and bear the brunt of the health harms of climate change. And we have to treat A to Z and age 0 to 150, but recognizing that cardiologists have another unique focus with which they address their patient population and specific risk factors that are especially pertinent to cardiovascular risk. And then lastly, too, we have to consider local healthcare infrastructure. So to imagine what type of environment you're trying to think about adding sort of a climate lens, as I often call it, to how healthcare is delivered in the location that you live. So with that in mind, I'm just going to sort of go through a thought exercise and think through how heat exposure, so obviously just one of many exposures of climate change that impact health directly and indirectly, but sort of talk through how heat has impacted my patient population in the Northeast. And again, recognizing there's going to be variations, as we've discussed, depending on where you live geographically, depending on your unique specialty, obviously, assuming most of you listening are emergency medicine, and then again, your unique practice location characteristics. So here we are, emergency medicine practice, right? We're in the middle, and we are influenced by multiple entities that are extensions of our healthcare system. all the way from the infrastructure of healthcare delivery to the pre-hospital, which is oftentimes considered sort of our own extension of emergency medicine practice, and public health, which I think it's probably never been clear that if you do not have adequate investments and attention to public health infrastructure, then the end result is health harms and people die, as we've seen with the COVID-19 pandemic. So let's think through, again, thinking about public health. So when you're thinking about, this is really the prevention aspect of it, right? That you don't even want to have individuals enter our healthcare system as a result of heat exposure. And so, for example, working with Boston Public Health Commission here and thinking through heat alerts, for example. So there was a great paper that came out that actually showed that the temperature at which an individual is hospitalized for a heat-related illness and the peak burden, so hence when is the hospitalizations related to extreme heat exposure reach its peak, varies quite a bit geographically. And for the Northeast, it was actually shown that at 86 degrees Fahrenheit is when peak heat-related hospitalizations occur. Now, oftentimes, right, 86 degrees Fahrenheit is not something that we working in an emergency department would stop. I have to worry about extreme heat exposure. But I think it's acknowledging that oftentimes heat is sort of that insidious aspect, right, that can continue to exacerbate underlying comorbid conditions and lack of socioeconomic support with which to protect individuals, and can lead to hospitalizations at a temperature much lower than anticipated. Now, one thing that this study actually showed was that heat alerts in many regions were actually going out after the peak hospitalizations had already occurred. So people are already being harmed and in our emergency departments and being admitted to our hospitals, and then heat alerts are going out. And I think that that really just highlights the need to have evidence-based driven information in order for us to better know how to prepare for this. And so as a result, for example, New York and other locations have actually lowered their heat thresholds and have actually showed that it saves lives and prevents hospitalizations. So that's an example from public health, just one aspect. Then we sort of move to pre-hospital. So we know that paramedics and community paramedicine are increasingly in a unique opportunity to really interact with our patient population within their own homes. So for example, could community paramedicine actually have where they can go and educate individuals around heat-related exposures and how to minimize their exposures, how to access cooling centers. And I think that that, is really an opportunity to think through, again, reimagine and innovate in how we can utilize our pre-hospital colleagues. Then I'm going to move a bit over here to the healthcare system. And so acknowledging that infrastructure is increasingly been shown to not be as resilient as it needs to be as climate change intensifies extreme events, again, from heat to extreme weather. So there was a really profound article that was published in the New York Times after Hurricane Michael. And it actually discusses in that article and really paints a picture for following the aftermath of this hurricane, that there were hospital employees that were sort of wandering around the grounds, and some of them were crying and dealing with their own emotions of the event. And then there were actually patients who were standing outside of a hospital. One patient was bleeding and the hospital was closed. And so that individual couldn't access care and actually, had to try to find another location with which to seek care. I bring that up as just one story of many that just shows that we need to have resilient infrastructure, because when these climate intensified events occur, that is the very time that our community needs us to serve them. So how can we, using climate models and locally, try to understand how climate change is going to increasingly put our healthcare system at risk for disruption, and where are the vulnerabilities, so we can prepare and invest in resilient infrastructure. The second piece is power. Right, we all know, and especially wilderness medicine, I mean, we can practice anywhere, anytime. Who needs power? Yes, well, we are a very unique subsection of emergency medicine. And so increasingly though, we have to think about what happens when power is lost. In the National Climate Assessment, one of the government's reports on climate change, has said that power outages are going to be increasingly more frequent due to not only extreme heat, but also due to the increased intensification of extreme weather. So an example here from just down the street in Cambridge. So there was actually, it was a 90-degree Fahrenheit day. And, you know, again, not that hot compared to most standards, but this hospital actually lost power. And backup generators don't actually, at least at this hospital, and that's true for many, don't actually supply power to cooling mechanisms. So the hospital actually got so overheated that firefighters had to evacuate patients from the upper floors of the hospital. In addition, the equipment became so overheated that even once power was restored, that they actually couldn't resume normal operations because that equipment had to further cool in the now sort of cooled environment. Now, again, that just highlights that we can have all the technology in the world and we can have all the skills in the world, but we need to ensure that we have a safe environment with which to operate. And the last thing I'll also say is that there is evidence that heat actually impairs cognition. And that's true for students when they work and study in non-air conditioned buildings during heat waves. And so what is that doing actually to clinicians, both within hospital infrastructure, which does not have access to cooling? And unfortunately, many of these events are going to continue to compound one another. So a hurricane may knock out power, but then a heat wave may follow. And so we have to think about those aspects in addition to thinking about our pre-hospital colleagues who are operating in these environments in people's homes or nurses who are doing home visits. And lastly is thinking about supply chains. So normally if I was in front of you in person, I would ask you to raise your hand. Obviously I guess we could do that virtually, but I'll spare that. But you know, the example we often talk about is intravenous fluids were actually produced in a factory in Puerto Rico. And following Hurricane Maria, that factory was disrupted, which caused widespread shortages of intravenous fluid across the US and even affected colleagues I had in Northern Canada and potentially broader. So now this is water in a bag, right? I mean, like if we think about simple things that we use for treatment. And so we had a shortage here in Boston. So we actually had a really strict criteria on who could receive intravenous fluid. So you can imagine the surprise of individuals when they show up to the emergency department, Massachusetts General Hospital, and they're there for gastroenteritis and they're expecting their IV, right? Of course. I mean, that's like standard of care. So you can imagine the responses I got when I literally handed them a can of Gatorade. It was an opportunity to educate people on how interconnected our world is and how supply chains are increasingly more and more vulnerable from something that can seem to happen in a far off place that has direct implications for us at home. I mean, you can also say, right, that the shortages we've had for COVID-19 PPE is yet another example of how our supply chains are not created in a resilient fashion that is going to continue to supply us with the supplies that we need at the location we need them, at the time we need them, in order to care for our patients appropriately. So now with all of that, as you know, a bit of the ethos around us, you know, let's just get to our actual clinical practice. So thinking about triage. So there's a patient case that I talk about in the paper I referenced on the previous slide. And that was an individual who, whose wife called 911 because he was confused. And so the EMS crew, who I know well at this point, they said that they climbed up to the top floor of this patient's apartment, which was in sort of some lower income housing in Boston. And they said that when they opened the door, that they were hit with a wave of heat that felt like they were in the Sahara Desert. Now they walked in, and this was in the middle of a heat wave, and they had no air conditioning, and they only had one window that was partially cracked. Now this individual, the wife stayed behind, and I often think about what happened to her staying behind. But this patient, so again, wheeled into our sort of middle acuity area at MGH. And we immediately, I was at the bedside and with the resident, immediately got a core temperature, and it was 106 degrees Fahrenheit. So again, this is like board question 101, right? So the diagnosis was clearly heat stroke, and we emergently moved him over to our highest acuity area and began cooling him. But we have to sort of, again, think about in our triage system that as, for example, heat stroke becomes increasingly more frequent, and this patient's chief complaint was labeled as fever. So fever and confusion, right? Oftentimes, sure, this could have been UTI with superimposed delirium. Could have been, except for the key fact of environmental exposure and the fact that EMS clearly said that their apartment had intense extreme heat exposure. So thinking about when we reach those thresholds where we know patients are being harmed, how can we actually start to implement triage protocols? The next phase 2 is around patient screening. So again, we know that certain patient populations are more prone to suffering the health harms of climate change. And so how can we screen for these individuals where oftentimes we may be the only providers that are providing that care to those patients? So for example, we know that not everyone has access to cooling. Now, whether that's even if they can afford an air conditioner or have access to an air conditioner, they may not be able to afford to run it. And then in addition, what happens if they lose power? Do they have a backup plan? As we discussed, right, power outages are going to become increasingly more frequent. Or again, another screening, what if patients rely on nebulizer machines? Do they have a backup plan if power is lost? So I bring those up just as a few screening questions, right, to think about that we can actually start to screen patients, that if they don't have access to cooling, then we can provide resources and we can truly save patients in a preventive fashion by identifying who is at greatest risk. Lastly, kind of talk about the diagnosis and treatment. So again, the sort of leaving the heat for a moment, but thinking about Lyme disease is becoming increasingly more frequent as a result of changes to the vector, as a result of climate change. And now every rash in my emergency department, and I hate rash complaints, I'll be honest, but you have to think about Lyme disease. But as these different climate sensitive diseases show up in new locations across the US, how can we ensure that we as emergency physicians actually have the climate dynamic knowledge to know when diseases are becoming increasingly frequent in the locations where we practice? Thinking about treatment, so there's actually a study that showed that for patients who are on certain combinations of medicines have an increased risk of suffering heat-related illness. Now, again, oftentimes I am not changing a patient's medications per se in the emergency department, but at the same time, right, we see patients in the middle of their peak vulnerability around this heat wave. Now, thinking about, we can say follow up with your primary care doctor, but oftentimes we know how that goes, if they even have a primary care doctor. And so with that in mind, should we start to identify if patients are on high-risk medications that make them more prone to heat-related illness? And should that then lead to subsequent screening in regards to heat exposure? Again, things that I'm not actively doing right now, but these are things that, again, we need to think about and grapple with if we want to adapt our practice to prepare and best protect our patients. Other thing around treatment is that certain medications, which is sort of basic pharmacology when you think about it, but albuterol and epinephrine, 2 life-saving medications that we often prescribe, that when those are left in extreme heat, for example, cars in the middle of a heat wave or just, again, 90-degree Fahrenheit days, that those actually have decreased efficacy. And so how can we educate, kind of connecting that with patient education, our patients around how to best protect their medicines to ensure that they have optimal effect when they need them most. So all of that is to say, right, that clinical practice is impacted by climate change. But let's kind of, using that as a framework and recognizing that we all know how COVID-19 has impacted our practice and have felt that very personally. I wanted to sort of talk about some of the parallels that I see in regards to these 2 crises. And again, one, the COVID-19 pandemic is a very accelerated, condensed crisis, and the climate crisis has been unfolding. But I think one key thing that is shown is that the COVID-19 pandemic has acutely shown us that when we ignore science and delay action or have ineffective or inequitable responses, then people get sick and die. And so, and I think that, you know, we all went into emergency medicine or medicine in general for different reasons. But as we think about that, we as health professionals, our voices have been elevated in the COVID-19 pandemic. And I've seen more colleagues on TV helping to share the message of public health prevention and what we can do for the COVID-19 pandemic than I ever have, at least in my career. And so our same need to amplify and unify our voices to help make these connections to protect our patients and educate patients has never been of greater need. And I think the same is true for climate change, in the sense that we are, and studies have shown that, you know, compared to individuals from the United Nations or, you know, local religious leaders, or even family and friends, or weather forecasters, that actually doctors and primary care doctors are the most trusted for delivering climate and health information. So that's an enormous, I think, responsibility and opportunity for us to use our voices, not only on our one-on-one patient encounters, but also thinking on a broader scale to continue to accelerate the engagement of the medical community. And one thing that's also very clear, at least to me, is that, you know, prevention has to be prioritized. So, I mean, that is the reason that we have altered our society, that I can't, you know, go see friends, that I wear a mask, because we're trying to prevent the spread of COVID-19. Because we know, having treated numerous individuals with COVID-19 in our emergency departments, that by the time their lungs are ravaged with this disease, that we can only provide supportive care. And similarly, you know, when a patient comes in with an asthma exacerbation because pollen levels are astronomically high as a result of climate change, then, you know, I can try to treat and, you know, their asthma exacerbation, but I'm putting a Band-Aid on a bullet wound and sending them back out to that exact same environment that contributed to them coming through my door to begin with. So we have to get to the root cause, which is the production of greenhouse gases. That leads me to the last point, and that's that we have to have a rapid and coordinated global response. Just like trying to procure ventilators by a state-by-state basis is enormously suboptimal compared to a coordinated federal response. And also recognizing that how one country manages their COVID-19 pandemic has immense implications for countries around the world. Because just like the virus doesn't respect borders, neither do greenhouse gases. And so what we do here in the US, as one of the greatest producers of greenhouse gases and drivers of the climate crisis, that impacts people halfway around the world. And so we have to have a coordinated response and work together in order to tackle these challenges. And then sort of the other piece is the intersection. So climate change is what's called obviously an ultimate sort of meta problem or threat multiplier. And that means that it underlies other problems, and it also makes current problems worse. And all of this has immense implications for health equity, just as we've seen that certain racial groups have been disproportionately impacted by COVID-19. They are oftentimes the same vulnerable populations for climate change. So as we strive to recover from this moment with a more equitable healthcare system that can help strive to tackle these health disparities, then we have to think about how these items intersect and how climate change multiplies and exacerbates existing issues. So some colleagues and I sort of laid out some thoughts on these intersections, and I want to highlight just 4 key areas as, again, sort of a thought exercise. So in the center, we know that the COVID-19 pandemic response goals are that we want to contain the transmission of the virus, and we want to try to improve our management of the disease when we treat them in emergency departments and hospitals and intensive care units. And our other goal should be to obviously improve health equity. And all of this is occurring within our existing healthcare system and public health infrastructure, which again, as we know, has never been clear how intersected these challenges are together. And these systems are, I should say, together. So thinking about too, and I sort of have, you know, the impact too of structural racism and health disparities, which are, again, sort of undergirding a lot of these different exacerbating factors that are contributing to worse health outcomes. So inability to physically distance. So that's kind of the first bucket, and that's the sense that that is one of the key goals of our attempts to contain the pandemic in the US. So we want to keep individuals away from one another to prevent transmission and prevent people from moving or traveling to other locations. But yet, as climate change intensifies extreme weather, we know that that is leading to forced displacement, so forcing people to leave their homes and make impossible choices, right? That, I mean, should I evacuate from this hurricane and risk going to a shelter and or some other location where I might be exposed to COVID-19, or do I stay and take my chances of the storm? And the inability to physically distance can be exemplified by individuals who don't have the ability to remain isolated in their homes during heat waves. I mean, are they, again, another impossible choice? Do they do that, or do they go outside? Or, and many of the air-conditioned locations that people commonly go to are no longer available because they're closed due to the pandemic. So again, just one way in which climate change is sort of threatening the response that we're attempting to achieve. In addition, I want to highlight sort of the lower left, and that's that many of the very same conditions that we know predispose people to worse outcomes from COVID-19, or including morbidity and mortality, that those same conditions are ones that are exacerbated by climate change, and that climate change is contributing to that disease burden. And I often also put in here too of just recognizing that the root cause is the combustion of fossil fuels, which is driving, again, air pollution, which we know particulate matter has immense implications for cardiovascular and pulmonary disease, which are key comorbid conditions for COVID-19, but then also producing the greenhouse gases, which are driving the climate crisis. And then the last piece is around the disruptions to healthcare access and delivery, as I already mentioned, and sort of went through, you know, some of the three key items. But that too, if your hospitals are already on the financial margins, and rural hospitals are closing at record numbers. And so the hospitals that remain mean that they are going to be having an even larger encatchment area that they, of patients that they need to treat, which means that if that hospital's ability to deliver care is disrupted, that means even larger ramifications for both acute care and managing chronic diseases for patients within the US. So what does all this mean? So, and that's what I really like to spend, you know, sort of the remaining discussion time and others, and hopefully this can continue to evolve even beyond this webinar, but it's thinking about integrated solutions. So I often sort of frame it as a climate lens. So how can we sort of view things through the recognition that climate change is, again, changing what the future will look like. And thus we have to think about how it's impacting our practice and care delivery going forward. So I think first and foremost, as we think about how to have integrated solutions for the climate crisis and COVID-19 pandemic, is realizing that many of these solutions truly can better prepare our emergency medicine practice and healthcare systems with an all hazards approach. So whether we're facing a pandemic or the intensification of climate change, there are many things that can have mutual benefits on both crises, and at the same time also help resolve and further address the health disparities, again, many of which can be driven by structural racism. So as we think about, you know, these aspects, I think first and foremost is that we have to work with one another in unprecedented ways. I mean, just like similarly, when you save a patient, that patient is saved by a team of people, from environmental services who clean the room, to the pharmacists, to nurses, to, you know, to the breadth of healthcare professionals. And similarly, you know, we have the treatments available here in order to address these crises. We just need the will with which to enact them and to work together to find them. So there are numerous ways kind of along the spectrum of how you can engage. And so that's everything from thinking about how to adapt your clinical practice, both for you, your colleagues, your local hospitals, how we can actually make our healthcare systems more resilient, as I said, to make sure that we can remain standing in our ability to provide care to our patients when they need it most. And similarly, and I think especially pertinent for this audience, is thinking about how our skills that especially wilderness medicine physicians have, how can those transcend and help educate our colleagues of how to work in normally high resource environments in these situations where suddenly the CT scanner is now overheated and not available, and how can we quickly and rapidly adapt our practice to be really dynamic and flexible. And I think all of that really speaks to thinking about how to create a climate dynamic workforce that we need moving forward, which sort of also then kind of plays into the trainee, patient, and public education. So how can we integrate a climate lens to emergency medicine resident education, to medical school? And how can we continue to educate the public as that key voice to help make those connections between climate and health for our patients and hence the public? Also to think about how can we invest in our public health systems in order to ensure that it can prepare to address both the public health challenges of today and increasingly for tomorrow. And thinking about healthcare sustainability. So actually climate change is driven in part by greenhouse gases, 10% of which are produced by healthcare systems in the US. And so thinking of that, we are part of the problem. So just like when we send patients out, we want to make sure that our healthcare systems are not contributing to the reason that our patient is then coming back through our door. And so how can we in healthcare take a leading role forward in order to understand how we can rapidly decarbonize? And I want to make a big plug right now that the National Health Service, which is the UK's National Health Service, actually announced today that they are the first national health system to commit to going to net zero by 2040, which is an immense announcement. And the way that they're pioneering and thinking through how to systematically and comprehensively decarbonize their environment and their healthcare system is going to resonate and have ripple effects kind of across the globe, and something that we hopefully can continue to learn from them as they continue to learn from what's been going on here. How we can also add a climate change lens to our research. And so recognizing that no matter what it is that you currently practice or engage in research on, that you can add a climate lens to that. So even if that's just a sub-aim to understand what does extreme heat, how does that impact whatever it is you study? In addition to having a whole generation of researchers who can be funded, so more funding for research is needed, to better understand and develop the evidence we need to chart a path forward to address climate change adaptation and in an evidence-based fashion. The last one, or last two, kind of in the regards to thinking about how we can sort of use our voice and use our lives with which to live this out. So not only do we need to speak out for our patients and recognizing that climate action is essential to health equity, and climate action is a prescription for health, we need to continue to express that. And there's nothing more powerful than a doctor in a white coat showing up to policymakers' offices and having that discussion. And we as emergency medicine physicians have flexibility to be able to do that, which is another reason why we are immensely equipped to be advocates in multiple ways. And then last thing, again, is sort of living that out in our lifestyle. So that's making personal decisions yourself in order to ensure that we can sort of move forward in a path where we are living our lives in a way that we know are not harming our patients as we try to minimize our own carbon footprint. So with all of that, I sort of have a potential discussion question we can kick off with, but I will turn it over to our esteemed leaders to sort of decide how to handle the question section next. And thank you so much for your time. It's been an honor.
Wonderful. Thank you so much. I feel like we were inspired, got yelled at a little bit, engaged. You should all feel ready to go and to start off running tomorrow. So this is just going to be an open forum. I, again, encourage you to turn on your cameras, post in the chat, jump in. There's only a handful of us. And so again, this is your opportunity to talk to us and ask those questions and have those reflections that so many of us have had over the last few months. And so this question is, what are some tangible solutions that you can do at your local institution or at the state or national level to chart a path towards a healthy recovery? So we'll open this up, but really want you to think about what have you seen and think about what we just heard. What did Dr. Salas tell us about all of the patients she's seen, right? Many of these things are observations and actions that we do every single day. But how do you articulate that and connect the dots to develop your own climate lens as an individual and as a member of a healthcare team in your institution? And so I will go ahead and open the floor to just some reflections. And if you have any ideas for solutions, remembering that we don't have the solution, right? But we have many different solutions and ways we can improve moving forward.
I can start. I think one thing I've noticed, by the way, hello everyone, I'm Caleb, I'm based in Boston. One thing I've noticed in looking at maps from heat risk from climate change, maps of where are the COVID-19 cases in Massachusetts, and maps of where are the opioid overdoses in Massachusetts, is those maps look fairly similar. And so while the mitigation of climate change has to come at a higher level, I think, than it has been, the adaptation from a geographic standpoint is probably going to line up with some of the things that need to be happening on two other major visible public health crises. So I'm curious on your thoughts, Renee, and on anyone else's thoughts on what can be done so that we are not trying to do three separate parallel siloed approaches to strengthening communities, and instead can maybe leverage some of that funding to address multiple things at once.
Yeah, that's a great point, Caleb. And I think, I've often said that if I could snap my fingers right now and somehow stop all greenhouse gases, right, we could all go back, kick our feet up. Unfortunately, that can't happen because we are currently sort of baked into a certain temperature degree rise because of the long lasting lifespan of greenhouse gases. And so we have to adapt. And, to your very point, looking at those maps is actually a really critical thing, because for many places, we need an evidence-based approach to understand where those vulnerable populations truly are. So recognizing that, public health resources are inherently, they're far from adequate. And obviously it's a whole other discussion, and I could do a whole lecture just on the need for investments in public health adaptation. But thinking about that very, fact, and recognizing that when we define sort of vulnerability, that definition of vulnerability opens up vulnerability to numerous different crises. And I think oftentimes, right, that, when you really get down but the big thing, right, is, and I often tell residents that, if you don't think about a diagnosis, then you definitely won't find it. And so similarly, when you think about vulnerability and thinking of how to help communities be resilient, you have to think about all of these crises together. And like you very much, well articulated, that you have to knock down the silos, right, and think about what the commonalities are, and how oftentimes, right, investments in certain aspects of resiliency can actually have widespread impacts across multiple issues. And sometimes it's just adding sort of that, with that additional lenses of you can then sort of just slightly tailor different approaches in order to ensure that it has optimal impact across a broad suite of crises. And so it's, again, sort of just thinking outside the box and thinking in a really broad, multidisciplinary way, because we need more voices at the table when we have these conversations to bring in sort of these very critical perspectives of other challenges.
Thank you.
I look forward to other thoughts too, if other people have thoughts.
I'm going to pick on Iris because she posted a comment in the chat that I thought was a very great observation. She said, "I'm a medical student from St. James School of Medicine. Yesterday, I attended a talk about neurology and tropical diseases and was surprised to learn how climate change, how changing patterns of migration for birds, for instance, is changing the distribution of viruses and other infections that we used to see in other parts of the world." But she said there was no recognition of the connection between climate change and medicine. And so anything else to add, Iris, feel free to jump in.
Hi, how are you? This is a really interesting talk. Thank you so much for allowing us to be present. No, I was just at that conference. It's all like so I think I was struck by the fact that we're taught this kind of I don't know, kind of regurgitated a text of how diseases are confined to these certain regions, and the curriculum anywhere. I mean, like, it hasn't changed to adapt to the reality that because the climate is changing, the distributions of these diseases is thus changing as well. So we have to kind of relearn or complement what we already knew. And I guess, I'm sorry that my Spanish is my language, so when I speak English, I get nervous. But anyways, so Chagas disease, I was really struck by it because it was talking about how it was, how we're taught that it was confined to the South America and Central America, but they're seeing a lot of Chagas disease in the US. And in many cases, there were, this was data covered by researchers in Barcelona, Spain, and they were recognizing how, in many cases, strokes in people who are very young, when they checked, they were these people where they were seeing strokes that were very young were people who were asymptomatic for Chagas, because most of the Chagas cases are asymptomatic, and because people are not aware that the distribution has changed, they were not correlating or thinking that that might be a possibility for these cases. So I don't know, I just thought that was very fascinating. And they just mentioned a lot of other diseases that were not just Chagas, but that was just an example that I was struck by.
Yeah, well, Iris, thank you so much for providing those comments, and it's amazing to have you on. So thank you for joining us. I think, there's kind of 2 points that come to mind as I reflect on your wise statements, and that's, I often describe our current understanding of climate change as an iceberg, which I recognize the irony of using that. But it's that that what our current understanding is sort of that mass of the iceberg that's above the surface. But I think the true impacts and what the reality is there's a far greater mass that's still beneath the surface of our understanding. And I think that's, what you point out is the fact that, the world is so intricately related, and we are constantly, finding ways in which things, one item or one action can have ripple effects sort of across other biologic systems and across other sectors of health and our society. And so thinking in that way, is recognizing that we, need to, again, really have an evidence-based research agenda with which we can kind of better understand these connections so that we can better prepare for them. But I also would say that, you have a really powerful voice as a medical student. And I oftentimes, after talks in the pre-pandemic world where we could actually engage face-to-face, but oftentimes it was medical students and residents, that were the most passionate about this. And you guys, you understand these interconnections. And you are the generation that is going to lead us forward in medicine. And so you have an ability to catalyze change in a way that, those of us further along in our career, I won't say old, but, further along in our career, just don't have the ability to do. And I bring up sort of a couple points. So one, when that occurs, you can raise your hand and say, great, so how is climate change actually impacting this disease? Or you're on rounds in a hospital and talking about an asthma exacerbation patient and oh, well, how are pollen levels, which are, again, due to longer pollen season and higher allergen levels as a result of climate change, how are those impacting our patient? And so you can sort of probe and force people to start thinking through what those connections are. And I think even from a systems level, you guys as medical students, you're paying for an education. And so you can go and knock on the door of your dean and say, what is our medical school doing about climate change? And what are we doing in order to ensure that our systems are carbon neutral? And, that they have to respond to you much differently than they would to faculty. And I think, again, so just really to empower you, that your voice is critically important. You are our future. And that, really diverse, interconnected viewpoints that you have is really what we need going forward. And so I encourage you to continue to educate others so they can adopt the same view.
Renee, I have a question about the NHS initiative. I'm not sure if you know the answer or not. Do you know if transition plant-based diet was part of the NHS initiative to become carbon neutral by any chance?
Yeah, so I have to admit that so a great question. So a dear colleague of mine, Nicholas Watts, is the one who's going to be leading that. And so I have to admit, I have seen the report is long and it just came out today. And I have not read the whole thing, but I do know that he is literally planning, and he and his amazing team that have been working on this are planning to literally systematically and comprehensively address every facet of the healthcare delivery system. So I cannot say with 100% certainty, given I have not reviewed that report in depth, but I feel confident in saying with 99.9% certainty that they are definitely tackling that because they really are seeking to take a holistic approach to this and recognizing that we need to just reimagine and innovate everything that we do. And I couldn't agree with you more that diet is a critical piece of that.
All right, I just wanted to take a moment while you think about any more questions and share my screen about a new initiative we're launching. So I will go ahead and share. All right. So many of you have come to our teams and said, what can I do? How can I get involved? And so we are launching the 50-state challenge as part of the Climate Change and Health Interest Group over the next couple months. And so as part of this, the website is now live. We'll share it on our discussion boards, but we are encouraging you to be active in your community and reach out to different people, different professions in your community, in your state, in our country, and just talk about climate and health. And so as Iris pointed out, they don't always make the connection on the health impacts, but you do, and you understand a lot more than you think. So no need to be an expert, you know enough, and just to get used to talking about many of these issues. So we have a few fact sheets, the Lancet policy brief, call to action, again, nonpartisan climate and health education as a way to advocate for our patients. And so we encourage you to submit a tweet. And then the best part is it's a challenge. And so you're going to submit a tweet, and then we have a map, and we are going to track progress across our country. And the goal is to get at least one meeting from every single state. Now, I knew about this, and so I had to help color in one state, but we want you to get creative and encourage your friends to join and be active because it's a great way to not only learn about what others are doing, but potentially collaborate on educational and research initiatives as well. Also a plug for future webinars. The next one is going to be November 2nd. We'll talk about climate and health education with Dr. Jay Lemry from the University of Colorado. And then December 1st, we will talk about environmentally responsible healthcare and what we can do to reduce our carbon footprint from the health sector with Dr. Jonathan Slutzman. And then a shameless plug, just today, Dr. Salas was lead author on a pathway to net zero emissions for healthcare from the BMJ. So encourage you all to read her as well as the team's article on greenhouse gas emissions. So that brings us to the top of the hour here. We'll be on, a couple of us will be on for a few minutes, but thank you all so much for coming and for your engagement and dedication. And we encourage you to go out and be your own climate champions within your institutions and communities.
Awesome. Well, congratulations on the 50-state challenge, by the way. I just want to give, a round of applause. Yes, and thank you all for joining, and thanks for having me. And this is just the beginning, right? So continue to work together and collaborate and find a path forward so we can recover in a healthy fashion from our current moment. So, and thank you to SAM and to Caitlin and Tracy for putting this together.